Thanks for joining us on the first stroke program webinar of 2020. My name is Al Tsai, and I am the director of the stroke program at the Minnesota Department of Health. Today, I will be providing an overview of where we are regarding stroke in Minnesota and talking about our activities for this new year. Your lines have been muted. We will be monitoring the chat box, so please type in your comments and questions throughout the webinar. Just hover your pointer over the lower part of your screen and click on the chat bubble in the menu that appears. The chat box will open. Make sure you select everyone, type your question, and hit enter. We'll answer your questions at the end. I want to apologize in advance to those of you who attended the webinar in August when I presented much of this same information. There are a lot of new coordinators and others who may not have seen this information, so our team thought that it would be good to present this to start off the new year. In Minnesota, as in the country overall, the stroke death rate declined throughout the 2000s. The decline in the stroke death rate has stalled over the past several years, however. The death rate in Minnesota has been consistently lower than in the rest of the country. Stroke was the sixth leading cause of death in 2017, our most recent year of data. For several years, it was the fifth leading cause of death, but dropped to sixth in 2017. However, that is not because the rate decreased substantially. Rather, deaths from Alzheimer's rose. Still, it is one of the leading causes of death in Minnesota. Disparities in the stroke death rate between racial groups have persisted for many years. In Minnesota, African Americans, American Indians, and Asians all experience higher stroke death rates than whites. This has been the case for a long time, and the disparities have not gotten any smaller. The number of hospitalizations for stroke has essentially remained unchanged over the last 2 decades. Despite our efforts to prevent stroke, there are a number of factors that have contributed towards this unchanging rate. Our older population at risk continues to rise. And even though cigarette smoking has declined, more are experiencing hypertension and diabetes. In summary, I regret to report a lot of disappointing news about stroke in our state. Stroke does remain a leading cause of death. The death rate has flattened out. Stroke is disproportionately impacting communities of color, and the hospitalization rate has not declined over the last several years. And these trends are similar across the country. But one thing we can and have improved over the last decade is the care and treatment that we provide when patients do have a stroke. First, we collect and report data on the time to CT scan for stroke patients. Over 73% of stroke patients in Minnesota receive a CT scan within 25 minutes. This has increased significantly over the last decade since we started collecting these data. In addition, we see that the improvements have been greater in hospitals that are designated as acute stroke-ready hospitals, primary and comprehensive stroke centers. Overall, nearly 80% of eligible patients receive alteplase within 60 minutes. We have, unfortunately, not been able to increase that percentage overall over the last few years. But that being said, we have seen a decline in the median time to treatment from 60 minutes down to 47 minutes. So there has been improvement there. Finally, the percentage of ischemic stroke patients treated with IV alteplase has increased from 4 to roughly 14%, or about 1,500 people treated every year. Of those who come within the treatment window, most get treated. So we need to continue to try to get more people to recognize their stroke and act to get to a hospital faster. That alone would increase the treatment rate significantly. In other words, the reason that most people who are otherwise eligible don't get treated is because they got to the hospital outside of the treatment window. Next, I'm going to talk about the program activities that we at MDH are working on. These include efforts in public awareness, the Minnesota Stroke Registry, designating hospitals, quality improvement, working with EMS, transitions of care efforts, training and education, and our partnerships. Our rates of patients arriving to the hospital by EMS have basically not changed over the last decade. I think this is crucially important because according to our Minnesota Stroke Registry data, only 1 in 3 patients arrive within the treatment window, as I mentioned. Again, the principal reason that a large majority of patients don't get treated is because they arrive outside of the treatment window. I mention all of this because we do need to do a better job informing the general public about what a stroke is, how to recognize one, and that they should call for an ambulance as quickly as possible. If we can be successful at that, we should expect to see a rise in the percentage of patients who arrive by EMS and who are treated. In order to support public awareness efforts in local communities, we have a toolkit of images and graphics that are free for anyone to use. We try to make a bigger push in May, which is Stroke Month, to get messages out about stroke. In addition, we're supporting a few hospitals with some small grants this year for them to produce short videos that tell a story about their stroke programs, but also provide an educational message about stroke that they can share with their community. Our second major effort is the Minnesota Stroke Registry. Most of you are familiar with the registry. We launched the registry in 2008 with 13 hospitals collecting and submitting data. This effort is part of a national registry coordinated by CDC called the Paul Coverdell National Acute Stroke Registry. We collect data from all hospitals in Minnesota. Participation in the registry is a requirement for statewide quality reporting and to be designated as an acute stroke ready primary or comprehensive stroke center here in Minnesota. In addition, every year we conduct chart audits on a sample of hospitals to assure that we are collecting high quality data. The principal reason for data collection is to identify areas for improvement and monitor the success of our hospitals. And we provide training and technical assistance to support you in this effort. The next major initiative that I want to talk about is the Minnesota Stroke System. We have been designating acute stroke ready hospitals since 2014. We currently have 93 acute stroke ready hospitals, 12 comprehensive stroke centers, and 12 primary stroke centers in the state. The reach of the system has grown considerably. In 2012, when we only had primary stroke centers in the urban centers of the state, 60% of the state's residents were within a 30-minute drive of one of these hospitals. The number of people with access to a designated stroke center grew as we began implementing the system. And today, over 96% of the state's population lives within half an hour of a designated stroke hospital. As we enter the third iteration of designations, we are fielding applications in April and October as usual, but this time site visits are a part of the application process rather than conducted after the designations have been issued. Now, we'll be conducting these site visits before we approve the designations, and that's something new. In addition, we'll be conducting mid-cycle reviews of all hospitals within 18 months or so of their designation. If you missed it, you can view the changes and an overview of all of this on the recording of our webinar from last month. We are also evolving in our expectations for performance and quality improvement. Hospitals are required to demonstrate that not only are they collecting quality of care data, but that they are engaging in a systematic performance improvement process within their facility. We are also working with hospitals on their quality improvement projects. One example of this work is implementing a process to provide feedback on stroke patients to EMS. We are working with a few hospitals on this process right now. In addition, we are hoping to launch a fun new program to recognize hospitals for their quality improvement work. Our Success Story Award program will encourage hospitals to tell simple stories about something they did to improve care for stroke patients in their facility. Our goal is to recognize hospitals at the statewide stroke conference with these awards, so please be on the lookout for this in the near future. We are also working with emergency medical services on a few different efforts. Our main activity is to help EMS agencies ensure that their pre-hospital stroke protocols are consistent with national guidelines. Through our time-critical response initiative, EMS agencies voluntarily send us their protocols so we can review them and provide recommendations for updates. We are also working on sending them a report card on how they are doing on a few performance metrics relating to stroke care. We also provide technical assistance, support training, and help them connect with their local hospitals. We are also working on improving life after stroke. The transition home for stroke patients is often very difficult. Our goal is to ensure that patients receive a follow-up contact and have their needs addressed after they are discharged from the hospital. We are asking that hospitals invest the resources to follow up with patients, as well as collect data about their health. This is our newest effort. We have been providing education and providing assistance in this area for the last few years and are now working with hospitals to follow up with their patients. We are also committed to providing and supporting training and education on stroke topics. We have a few online education courses that are available for free on the MDH Learning Center and are continually developing more courses. In addition, this year we will be providing a few more webinars on clinical topics, and we will continue to support the stroke conference that is hosted by the Minnesota Stroke Association. Please see our resources webpage for more information about our training and education opportunities. Finally, I want to make sure to note that we convene a couple of groups. I work with and try to meet with regularly a group of stroke neurologists to discuss issues regarding stroke treatment statewide. If you would like your stroke neurologist to get connected to this group, please have them contact me. We also convene a bi-monthly call with the stroke coordinators of the primary and comprehensive stroke centers. And of course, we have this forum that all are welcome to attend. That's the program in a nutshell, and so I hope that you have been able to jot down ideas and questions for how you and your colleagues can interact with us and our programs. Most of you are connected to us in at least one of these areas already. It's a wide range of work that we believe is important to address in order to comprehensively address stroke in Minnesota. Please contact any of us when you have questions or have any needs. You can count on hearing from one of us at some point. So I wanted to make sure that you can put a face to the names of the members of our team. So there is me, Nikki Anderson, who is our stroke system nurse specialist, Michelle Gray Ansari, who's our Stroke System Designation Coordinator, Ali Fuji, our Stroke Registry Coordinator, Catherine Johnson, who coordinates our EMS work, Kay Hertzfeld, our Transitions of Care Coordinator, and Julie Hofer, who is our Research Analyst. We're also going to be welcoming a new team member in a couple of weeks, and her name is Mimi Ameling, who will be our Evaluation Specialist. These slides will be available after the call, and this presentation will be posted on our YouTube channel within the next couple of days. And that's it. Do we have any questions?
Feel free to chat in the chat box if you don't want to ask out loud. Otherwise, you can unmute your line by pressing *6, and we have plenty of time to address any questions you might have about 2020. Okay. Well, we'll be on the line for a couple more minutes. In the meantime, I did put in the survey link right into the chat box here, so that is live. We do appreciate any feedback you have for us on this webinar and really kind of forward thinking about our webinars in the coming year to hopefully really try to meet your needs, ideas for clinical topics and whatnot.
Great. Well, thanks for joining us today, and we'll make this a short webinar this month, and we'll talk to you next month.